Good morning, and welcome to the first FOKUS Patient Future Days and the first day of 2 days of this year's FOKUS Patient Future Days. And that will be the hardest part of the day, I guess. My name is Mattias Hellström. I'm CEO of Citizens Affairs and co-founder of the initiative FOKUS Patient. I will take the opportunity to welcome delegates, speakers, participants from 9 countries and various stakeholder groups for 2 days of interesting keynotes, seminars, panels, networking events here in Stockholm, Sweden at Elite Palace Hotel. I also want to specially address our sponsors and exhibitors. That is a key factor in making these future days possible. Thank you for your support. You have some of them behind me here. But before welcoming the creator and program and content manager of Future Days and founder of FOKUS Patient, Penilla Gunther, some housekeeping rules. So emergency exits is behind the curtain here, the entrance, and on the opposite side of the room. Toilets are located on your left outside in the hallway, or on the far right at the end of the hallway. Lunch is served at the restaurant just outside the registration. This is Vasasalen. On the other side, we have Vanadisalen. We will have a wall in between for the parallel sessions, so you don't need to go far. Wear your badges at all times. When lost, if having questions, please find any one of the FOKUS Patient hosts. We are easy to find. We have the logo and are dressed equally. Please use the hashtags FOKUS Patient and Future Days when you post all your social media posts for today. And use the opportunity to network with all these brilliant people representing so many different organizations here at the conference. And of most, enjoy those days. And now I want to hand over the microphone to my colleague, Penilla Gunther.
Well, it's a pleasure for me to see you all and that you have heard my requests or seen my request. And I'm not a shy person when to ask people to come and to come to Sweden. You know, I think it's so important that we learn from each other, and we learn from each other from different countries, from different angles, from different organizations, companies, and so on, and share that knowledge with each other. And not the least, this is in-person meeting. It's about networking. So if you go from here today or tomorrow without have made any new friends, then it's up to you. So please feel very, very welcome. We will do our best from FOKUS Patient organization here, our networks. We're 8 volunteers also helping out with these conferences. And I also like to say that the theme for this year's conference and the future days is about to see what will happen in the future. What can we have learned from the experiences from far away in the years or very close in time with the pandemic and so on. And the biggest newspaper in Sweden just had this article last weekend about researchers and what will be the next pandemic. So maybe we will hear more about this in the following panel discussion, but not the least from our first keynote speaker. And I'm so happy to welcome you, Robb Butler, from the World Health Organization. A big hand for Robb.
Thank you. Thank you. Thanks very much, Penilla. I'll stand up here, but I know myself. I will move around as I speak, so you have to bear with me. 2,250. 2,250. That's the number of attacks on healthcare in Ukraine after 3 years of war. 4.2 million people are in need of mental health services, and almost 12,000 people are in need of prosthetic limbs, upper limbs, lower limbs. Every second infection, healthcare-acquired infection in hospitals or in health centres, is an infection that is highly resistant to antibiotics. As I left Kiev yesterday to come here, I've just spent 10 days in Ukraine, it struck me that I should start today's talk with acknowledging the resilience of the healthcare system of Ukraine. Not only are they facing unfathomable, we simply cannot imagine some of the strain that that health system is under. Despite this, they have interrupted polio virus circulation in Zakarpattia. They have expanded their antimicrobial resistance surveillance platform and are about to introduce a very, very ambitious new immunization program, immunization schedule for 2026. They're performing miracles, this health system. Now, why am I speaking to you? You're all looking at each other thinking, this guy's at the wrong conference. He doesn't understand why he came. Why am I bringing this to your attention? I'm bringing this to your attention for two reasons. The first is that everything that we discuss over this next 2 days should be put relative to what else is going on in the world in some of these crises, particularly in crisis and emergency settings. We are so privileged to live here, to discuss what we're discussing, beautiful, safe environments. On Friday night, I was in a bunker with the Minister of Health, holding the third of 3 meetings. We had to take it in a bunker because the missiles were coming in. They didn't thankfully arrive. They were shot down. But we spent it in a bunker for 2.5 hours. It was freezing cold. Those kind of conditions we'll never meet. And you know this. You know we're all very privileged. But the reason I'm bringing it really to your attention is for the second reason. We can control and we can influence the factors that compound the impact of that war. What we're seeing internationally at the moment, the erosion of multilateralism, the shift to more transactional foreign aid platform and development. So transactional meaning our governments are shifting their aid and humanitarian assistance to a format that benefits them and doesn't necessarily start with the first point of benefiting the recipient. So erosion of multilateralism, the erosion we're seeing of values and rights and morals that we thought were untouchable in the European sense, around gender equality, around rights. We have to maintain in every single discussion we have the importance of those values. They are being eroded, they are being attacked, and I wanted to start this talk with saying, looking at the program that we're about to engage in over the next 2 years, let's keep this in the forefront of our mind. Our responsibility as a community is to assure equitable, universal access to health, well-being. It is around justice. It is about rights. It is about responsibility that we have as healthcare providers. This is what we can do to make the difference. So I wanted to start with this rather emotional plea to you because I think it's important that we keep this in mind on each of the topics. And I'm really grateful that I can be here today. I'm going to be with you for the whole day. I'm going to go into listening mode soon because I'm really interested to take part in all of the discussions. So what I started to think about on the road out of Kiev would be, how would I introduce something in 12 minutes that was going to give you a sort of a ground setting point for this conference? And I thought I would focus on what we at WHO are hearing from the member states. So what we're embarking on at the moment, and when financial restriction comes, when you find yourself short of funds, which is what WHO is experiencing at the moment, you find yourself focusing on the most important things. And the most important things, or mega trends, over the next 5 to 10 years that will impact our healthcare systems and the way in which we develop our healthcare systems and policy are fourfold, and I'm going to take us through all four. This is what ministers of health, what director generals, what secretary generals in each and every member state of our 53 member state European region are telling us that they need support on. The first of these megatrends, climate change and environment and health. The second of these, demographics, a shifting demographic, an aging population. The third of these, an unfinished agenda on NCDs. And the fourth of these, which we'll come to more in our panel discussion, health security. Climate change. Let's start with the first. Climate change. 520 premature deaths in the European region due to the air that we breathe. 120,000 of those are related to indoor air quality. In 2023, we saw 63,000 excess deaths due to heat in our region. We have 1 in 5 people living in environments where with excessive noise, and we've seen a 5-fold increase of climate-induced or climate-related emergencies, extreme weather events, just over the last 25 years. So huge, huge climate change challenges ahead of us. In each of those emergencies, of course, we then have our emergency responders. We have emergency responders suffering mental health issues. We have a huge mental health challenge in terms of the youth and eco-anxiety or climate anxiety. My 2 daughters would certainly fall into that category. So we have, and of course, climate is changing the face of diseases in Europe today. We have emerging arbovirus transmission in Southern Europe. Arbovirus, so tick-borne diseases, vector-borne diseases, malaria and dengue in Europe. Transmitted in Europe, not imported, transmitted in Europe, indigenous. I have a local bike path near my house in northern Denmark, northern Zealand in Denmark, and I could not bike this last summer through half of the forest because of tick-borne encephalitis. I never thought I would see the day where tick-borne diseases, Japanese encephalitis, and vector-borne diseases would pose a risk to me living in Denmark. So these vectors, this tiger mosquito moving fast, these ticks carrying these diseases, arboviruses, existing, surviving in warmer climates, very much climate-induced. So our health systems, of course, are going to have to adapt to this. They're going to have to adapt their surveillance. They're going to have to adapt their policies. They're going to have to adapt their workforce, because most GPs in Germany have never seen a case of malaria before. So our whole training and education will need to change. We will need to adapt our entire health system to climate change. On the other hand, we've also got to mitigate the impact of climate change. Health systems contribute between 4 and 7% of all carbon emissions in every member state in the European region. We just heard from the Dutch Minister of Health at COP, it was back in November, but it feels like yesterday, COP in Azerbaijan, where the Dutch Minister of Health stood up and said 7.2% of all carbon emissions in Holland, in the Netherlands, are due and created, and the health system is responsible for those emissions. So we need, of course, mitigation measures in place. If the health system globally was a member state, it would be the 5th largest member state emitting carbon greenhouse gases. That's a phenomenal figure. So clearly we have an adaptation in our health systems necessary, and we have a mitigation responsibility of our health systems. Particularly on the mitigation, but also on the adaptation, we're going to have to take full control and leverage the full advantage of the technological revolution that we're experiencing, and also look at different models of care, and the delivery of our health system will have to change as we move forward. And that brings me to my second. Remember, there were 4. So the second, demographics and the aging population. By the year 2050, we will see a triple, 3 times the number of people living over the age of 80. We will see twice as many people living over the age of 65. That poses an incredible, almost existential for the health system, threat as to how we deliver healthcare to that population and ensure that populations that are aging in a healthy manner. This is no longer about adding years to life. This is about adding life to years. And we've got to take that shift to make sure that life course health is a predominant part of our future health systems. That people not only age healthily, but they are active and that they take part in society. 37%, that is the figure, of people, an increase of 37%, the number of people that will not be working in our economies in Europe by 2050. That is a phenomenal increase. We already have a healthcare worker deficit, so we're already short of 1.2 million health workers in the European region. So this is a, I'm not going to say a ticking bomb because that sounds a little bit drastic, but this is certainly a crisis that we need to address from the workforce perspective and from the life course perspective in terms of delivering good health. I'm a particular advocate of healthy aging, particularly active aging. My father is an 81-year-old Ironman who just 6 months ago, I actually went to watch him in Hawaii at the World Championships. He's number 4 in the world for Ironman. He does a full Ironman. You won't believe it, but 16 hours it takes him to complete the Ironman at 81. So I'm coming from good genes, but it also means that I have no choice but to support the healthy aging agenda, which is very important, of course, across the region, has huge health and, of course, financial burden for our societies. The third point that I wanted to raise, NCDs, the unfinished agenda on NCDs. It is great to see the UNGA high-level meeting this year will be focused on non-communicable diseases, a vastly under-resourced area of each and every one of our health systems. At WHO, we talk about pockets of poverty. This is our one outstanding pocket of poverty over the 16 years I've been working with WHO has been on NCDs, which is remarkable, given that NCDs claim 90% of the lives in our region. It is remarkable, given that 4 industries contribute to 80% mortality and somewhere around 80%, 75% of lives lived with disability. Those 4 industries, of course, carbon, food, alcohol, tobacco. Huge commercial interests pushing back, a lack of political commitment that hopefully we will address at the UN General Assembly in September this year. The commercial determinants, the social, environmental determinants, we focus on very much at WHO. I haven't really spoken much about WHO and what we do, but I thought maybe I'll save that till a little bit later. But one of the areas where we're finding a lot of positive feedback of our work is working around the commercial determinants, tackling the commercial determinants of poor health, and introducing behavioral science to our work. I'm a behavioral scientist by trade, so I'm not going to get onto that topic because otherwise I'm speaking until lunchtime. So I'm swiftly going to move after that and not go down that rabbit hole. This is a 2-part keynote. So that was my first part. I'm going to be coming back on the panel. And as agreed, I'll be saying a few words to introduce the 4th component that I mentioned, health security. So with that, I'd like to thank you again, Penilla, for inviting me to say these few words of opening. I hope they were useful. I'm really looking forward to the discussion today. Thank you very much for including WHO here in participating. Thank you.
Thank you so much, Rob. And you will be back in the panel, but in between, we will have a short announcement. Well, that's the wrong word, but a speech also by a former colleague of mine. Vi ska få en liten inspel här från Europaparlamentet mellan här av Jessica Polfjärd, en för detta kollega till mig som har suttit nu ett tag i Europaparlamentet. Hej Jessica!
Hej Penilla!
Vad roligt att du kan vara med oss, vad fint du har det.
Tack för inbjudan. Bara sätta på här bakom så ska det se vårligt ut.
Ja, verkligen. Men välkommen till oss här på Elite Palace Hotel och jätteroligt att du kan vara med. Och vi är väldigt glada över att du har tagit plats i den här kommittén som har etablerats. Äntligen kanske man får säga. Så ordet är ditt, varsågod.
Thank you, Penilla. And I can just underline what Penilla said, that we've been former colleagues and that she is not shy. She's been a very good colleague. We've been working together in politics, and I'm glad to see you in this new role of yours. And I'm also happy to get an invitation to this important meeting. So I gladly participate. And I will also just comment on the former speaker, because I think that what is on top of everyone's mind at the moment is really the geopolitical situation. And that is also what we're doing in the European Parliament. But the most important is what was also stressed, that we have to tell the truth. The truth has to be told, and the danger in those who are silent, even though they know the truth, is what we really have to fight against, because this is not really a balance. It is very easy in this regard, I would say, to tell what is the truth and what is not. So I think that is important also. And what you have invited me to speak about is the European Health Union and this new standing committee for health and medicines in the European Parliament. We had a lot of experience during the pandemic and during COVID, which has also been carried into the new work and in the new agenda for the newly elected Parliament. We know that health policy impacts us all. Disease knows no borders. That is why it's vital that we as Europeans work together on health issues. The European Health Union and closer cooperation in health policy are important aspects to prepare Europe for the future and to strengthen our healthcare systems. That is why it is positive that we have now established this committee, this permanent committee on public health, in the European Parliament, where I know that we will have a full agenda, and I am the only representative from Sweden as a member in this committee. And as the committee was recently created, we are still in the process of starting our work, but there is no shortage of important issues to be considered. And strengthening and securing Europe's healthcare system is one of the essentials to meet the needs of patients, to be able to provide necessary treatments and help European citizens. But in the times we live in, where the global environment becomes increasingly uncertain, it is sadly to say that it is also a matter of security policy. That means that we must also view health policy through a preparedness lens. Europe, and Sweden especially, has a successful medical industry, but we are not today self-sufficient. And we must work towards identifying and find vulnerabilities in the medical systems, especially in our supply chains, when we are dependent on other countries to get what we need in terms of materials. And for that reason, the Commission presented the proposal for Critical Medicines Act last week. The aim of the CMA is to provide tools that allows us to strengthen the security of our supply of critical medicines, not least with the aim of bringing more production of basic medications back to Europe. This will now be one of the areas where the Public Health Committee in the European Parliament will focus on its work. It is one important topic, and we will analyze the Commission's proposal and see where we can improve it from the Parliament side. And the proposal contains several measures: increased support for companies investing in the pharmaceutical manufacturing in Europe by lowering the administrative burden, but also potentially with financial investments. It also contains provisions for European countries to work together when procuring medicines to increase their purchasing power, as well as allowing for prioritizing medicines produced in Europe. I believe we must strike a balance between attracting more investments in Europe and relocate more production here, while also still retaining an openness where we can cooperate with the partners. And we also must make sure that we ensure that our current medical sector is given the right conditions for innovation and growth. The pharmaceutical industry in Europe conducts cutting-edge research, and it is one of the forefront in innovation. It contributes to our economy, not least in the Nordics, and strengthens Europe's competitiveness on a global stage. And innovation in the pharmaceutical industry is also an important aspect of preparing for the future. New medicines, tools to counter anti-AMR, and new modes of production are all components that contribute to making Europe more secure and healthcare stronger. In that respect, we are also working on a revision of the EU's pharmaceutical package. The Parliament has already adopted a position, and we are now waiting for the Council to do the same so negotiations can get started. This will be another major mission for the samt committee, and we will start as soon as the Council is done. And for me, the position is clear that the EU must have a competitive and innovative pharmaceutical industry. That means that we must have rules in place that are clear and easy to follow, so as not to create unnecessary burden and heavy administrative burden. We must also reward innovation. Research and development on new medicines is a risk and a long-term investment. Those who do develop new medicines must have appropriate incentives to continue to do so and to do it in and within Europe. Europe is already a world leader in medical innovation, and we are in a good position to continue to be that. We have an established medical industry, a skilled workforce, and a history of innovation. New measures in the field of healthcare policy must embrace this, while also increasing the ties between our various countries. Europe is stronger when we work together. That is the true whether we speak of climate issues or defense or healthcare. So thank you for the invitation, and I hope that you will have a productive and successful conference in Stockholm.
Much, Jessica. And we will be back to see you. Yeah, to see you again, and hope to see you also, in person in Stockholm next time. Thank you.
Thank you.
And we will continue with a panel discussion and welcome Robb back to the stage, and together with Annette Kraus from International Vaccines Institute and Olivia Wicksell from the Public Health Agency, I think. Yeah. And with the moderator, Anders Blank. I leave it to you. Thank you.
Thank you, Penilla. Good to see you all. It's a pleasure and a privilege to be able to moderate this first panel session today, where we will deep dive into one of the most important things for this conference. It's the headline for this session is Resilience and Actions in an Uncertain World, which has been very, very well framed by Robb in his introductory speech. So, given that, we go back to the sort of headline for the entire conference, which Penilla presented at the very start, that how can we create a sustainable healthcare system prepared for the future challenges, and how can the life science sector support this? So with that, I will welcome back Robb to, continue where you actually left us hanging on the first subject, is health security. So you will focus your keynote start here as the health security piece, and then we will have short interventions by Anna Kraus, and then from Olivia, and we'll take it on there from a panel discussion. So please, Rob.
Thanks very much, Anders. So we talked about health security, and we talked about future threats, the topic of this panel. So I'd like to just start with looking at some old foes, as I call them, our old enemies or old threats, and then some emerging and unknown threats. 30 years ago, I was working in Cambodia on the introduction of the female condom. We had a pilot project on sexual and reproductive health, and we were working on, of course, addressing HIV, sexually transmitted infections, and also, of course, birth spacing amongst a small community in Cambodia. If somebody had told me 30 years ago that I would be sat in the European region 30 years later and experiencing an increasing epidemic of HIV, despite the fact that we have antiretrovirals that drop our viral loads to a level where they're undetectable and untransmissible, despite the fact that we have pre-exposure prophylaxis, now long-term pre-exposure prophylaxis, despite the fact that we have widespread condom availability throughout Europe, I would have laughed at them if somebody had said, in 30 years' time, you'll be sat in Europe and you'll be experiencing an increase in HIV incidence, about 30 to 40,000 new cases a year, and 52% late diagnosis. So we have all the technology, and some technology I've even forgotten, because we have same-day testing, home testing, same-day diagnosis. Think about where HIV technology has come in just the past 30 years. We're still seeing late diagnosis. We're still seeing tens of thousands of new cases. This is not a technological challenge. This is a human challenge. This is about stigma. This is about discrimination. This is about some of the things I mentioned at the very beginning of today, the erosion of values and morals and recognition of people that somehow don't fit into our old-fashioned boxes. It's exactly the same with MDR-TB. This region has the highest rates of multi-drug resistant tuberculosis in the world. Thankfully, we have new, shorter 6-month regimens that are becoming available. But the fact that 90% of MDR-TB, multi-drug resistant TB, is in Ukraine and Russia, but is impacting economies in the EU, largely due to migration, due to refugees, due to importation, if you like, of MDR-TB. This really emphasizes to us that some of our oldest threats are still pertinent and still important for us from a health security perspective, because a threat anywhere is a threat everywhere. I've worked with vaccine-preventable diseases for many years. Polio can quite literally fly in first class from Islamabad tomorrow. We have 5 member states of the EU that currently have circulating vaccine-derived poliovirus type 2. In the EU, 120,000 cases of measles, 68,000 hospitalizations of measles last year, and 38 deaths of measles in Europe. I'm laughing because it is almost a joke. In the European region, where we have all the ability and all of the financial ability and competence not to see a totally vaccine-preventable disease burden our health systems. Pertussis, 9 countries reported deaths of under 1s to pertussis, a totally vaccine-preventable disease last year. Something like 140,000 cases of pertussis. So clearly, whilst we talk about pandemic preparedness, while we talk about preparing for this disease X, let's all keep in mind that there are some older foes and threats that still threaten our societies in very meaningful and real ways. The reason I focus particularly on vaccine-preventable diseases is because measles is the best indicator for a shortcoming of your health system, for suboptimal health system delivery, suboptimal primary healthcare performance, and an excellent tracer or proxy indicator for universal health coverage. I don't accept that any minister or health authority can stand up and claim universal health coverage if they're having tens of thousands of measles cases. It's just not possible. It is the best indicator of a shortcoming in our health security and the health security of any state. So I will stop speaking in a moment, but just one more point if I could. And then we have to look at emerging diseases. And AMR was mentioned, antimicrobial resistance was mentioned by the previous speaker, 135,000 deaths in the European region, primary infection, and about 340 through secondary infection, antimicrobial resistance, and where antibiotics are not capable of treating infections. Here we have to do a better job, and I really have to applaud Sweden here in terms of taking the AMR leadership globally. At last year's UNGA, Sweden hosted a high-level meeting of ministers in the European region and leadership in the European region on AMR. We're still not there, but thanks to, of course, Sweden has one of the few countries, very few countries, and was the first country in the world to have an AMR ambassador in Malin Glaper, who has done great work internationally as well to spread the good word and to make sure that countries step up to their commitments, because they're not currently stepping up to commitments. 48 national action plans in our 53 member states, 12 are fully financed. So action plans don't make a toot of difference if they're not financed, if they don't have commitment, if they're not, they sit on a shelf and WHOs tap themselves on the back and say, well done. We've got another country across the line with a national action plan. 12 of them are fully financed of 48. Globally, it's somewhere around 11% financed. Antimicrobial resistance is everybody's business, but it's nobody's responsibility. So for me, antimicrobial resistance is the challenge, is the emerging challenge where we see a non-commensurate or not equal. It's like the threat is not commensurate with the actual action being taken. Where I see the biggest divide, I would say, is on antimicrobial resistance. So I wanted to mention that as a particular point, because also we're bringing forward an accountability index at WHO that will hold countries a bit more accountable. We will start benchmarking country performance in our region, and the rest of the globe is looking at this accountability index with some interest, because of course it will be carried, we hope, to a global level, and we'll start ranking, and the Americans say ranking and spanking. I don't particularly like that. But we will certainly start benchmarking country performance as we do on polio eradication or measles and rubella elimination. So with that, I think I'll just stop. Of course, the big piece that is missing here is the detection, preparedness and response to pandemic preparedness. And the other element, which I won't speak to, which I'm sure we will get to shortly, is the infodemics and the lack of trust, which was inferred by our previous speaker as well. Because really, misinformation and disinformation is quite honestly our biggest health security threat today. It's more dangerous than the diseases themselves. But I'm sure we'll get to that shortly. I'm sorry for going on a little.
No. Thank you, Rob. It's very interesting. I think this is a very, very good bridge to Annette. From your perspective as a senior research scientist at International Vaccines Institute, what's your perspectives on this resilience piece? And Rob referred both to primarily the vaccines piece. I think you have some slides.
I have some slides, and maybe I just stand over here so not in the way. Thank you.
Good.
Give you just some ideas about what we do. So thank you very much for the invitation. I'm very glad to be here. International Vaccine Institute. Next slide, please. Question is, who are we really? What do we do, and where do we do it? So IVI is a UN-chartered international organization dedicated to accelerating vaccine research and development for global health. Our mission is to discover, develop and deliver safe, effective and affordable vaccines, particularly for the world's most vulnerable populations. Our work spans, you see it up here to the right, the entire vaccine development process from discovery to epidemiological surveillance. So we conduct preclinical studies, we facilitate process development, we ensure manufacturing support and advance clinical trials. We also conduct health economic studies and support vaccine introduction campaigns. And last but not least, we assess disease burden, monitor antimicrobial resistance and vaccine effectiveness, always, of course, together with our partners. So to expand down to the left there, to expand our impact, IBI has established offices and collaborations worldwide. Our headquarters are still in Seoul in South Korea, and we have now the European regional office here in Stockholm, just around the corner on KI campus, as well as a country office in Vienna in Austria. New country offices are also established. Kenya is now our regional Africa office, and Kigali in Rwanda is hosting our country office in Africa. So IBI works here to the right, down with over 40 partner countries, from Asia to Africa to Latin America and Europe. And through these partnerships, we are creating sustainable solutions for infectious disease prevention. On the next slide, we see IBI's progress across the three strategic pillars that we see here. So it's the funder diversification, new vaccines, and long-term sustainability. So over the years, you can see that here on the graph, IBI has seen steady growth in total activities and funding, increasing from about 21 million in 2015 to projected 120 million in 2025. It is important to note that this growth is driven by diversifying our funders, our funding sources, and also by broadening our vaccine portfolio. So is this a pointer here, right? Yes. So you see it here in the graph. In 2015, IBI's funding was primarily due to a large donor like, well, it was BMGS and the Korean government. In fact, 75% of our funding came from only one donor, which was BMGS. And now in 2025, we have considerably broadened our funder, our number of funders, and we are working together with governments, private companies, and global health organizations like CEPI. So while the funding from BNGF, for instance, has in fact increased, it is now only representing about less than 20% of our total funding at this point. So this diversification really ensures sustainability and reduces the reliance on only one or two key funders. Same to our vaccine pipeline that expanded tremendously. In 2015, we was focusing on cholera, typhoid, and dengue. Whoa, it's a little bit, yeah, some attention here. So today we're working on a lot more, on a very diverse list of pathogens. So we've included COVID and HPV, hepatitis, chikungunya, and other important pathogens like strep A. So I think it's really safe to say that this shift over the last 10 years really reflects IBI's commitment to addressing emerging global health threats. So taken together here, through strategic funding, diversification, and expanded vaccine research, IBI is ensuring long-term sustainability and a broader impact on global health. The next slide illustrates IBI's... Next slide. Yes, thank you. So this illustrates IBI's efforts to enhance vaccine manufacturing capacity in Korea. That's why we're headquartered in where the business started. And this is through strategic partnerships and initiatives. So over the past decade, IBI has in different steps established vaccine product development partnerships with Korean manufacturers and agencies. In 2018, I'm jumping here a little bit, the Right Foundation was established, co-funded by the Korean government, the MGF and manufacturers, and they support heavily R&D for global health, including cholera conjugate vaccines. In 2021, here to the right, the K Vaccine Hub was established as a center of excellence supporting Korea's biomanufacturing sector. It includes a global training hub and networking initiatives to globalize really Korea's vaccine industry, to just name a few activities. And through these efforts, IVI is strengthening Korea's vaccine ecosystem, which in turn really ensures global access to essential vaccines. The next slide, which is like to give a brief overview of the importance of Sweden as a gateway to for us here at IVI, and which offers so many benefits. So Sweden provides, of course, IVI with an access to top talent and strengthens its role in the European life science ecosystem. It enables IVI to expand its engagement with European stakeholders, and here we can just think about the time difference to Korea, which hampered collaborations in the beginning. And Sweden's very strong life science and global health networks help, of course, IVI bolster research and development efforts. IVI is partnering with Swedish institutions, to name Karolinska and of course, Public Health of Sweden, just to name the locally closest ones. It offers, of course, also for us new funding opportunities and enhances the engagement with key regions, for instance, in Africa, again, thinking about the time difference, which is, of course, much easier to live with here. So these collaborations really drive innovation in vaccine development and global health security. IVI's vaccinology course, in partnership with Swedish institutions here in the center, helped develop the next generation of experts, and Swedish office is actively growing. We're foreseeing a workforce of about 30 people by the end of next year already, 2026. And the next, I think in the interest of time, I just leave it here, the next slide, for a second for you to look at. Our global health impact is based on needs that drive innovation and result in impact. You can look at it. In the meantime, I thank you very much for your attention.
Thank you, Annette.
And
we'll come back later. Thank you so much.
Absolutely.
Big hand for it.
Yeah, thank you.
So moving over to you, Olivia, with your nowadays the Director General for the Public Health Agency of Sweden. Before that, many years with the National Board of Health and Welfare, and also for many years, one leading expert in the WHO family as well. What's your perspectives on these challenges that Robb started with and then Annette filled on? So please feel free to elaborate on your perspectives on the 5 years after the pandemic, I would say also. So please.
Thank you, Anders. And I think I'll skip my slides and turn to this discussion right away. So thank you, Robb, for bringing Ukraine into our room, and also for bringing profound values for a democratic society like equity and access to care, human rights. I believe what you are saying is that we have to be advocates and have to give voice to those values nowadays, so they are not to be taken for granted. And that's one task for the Director General as I. And you are lining up a lot of challenges or crises, and I recognize them. And of course, I totally agree with you that those are our main challenges. And coming to solutions, then I don't think we can tackle them one by one in silos, but we have to now introduce more policy measures that can and should cover different outcomes. So one policy measure can address different crises or challenges. So I think that's a really important task for public health policy, to generate public health policies that gives multiple desired effects. And for one thing, to take two examples, for example, To promote active transportation. Yes, how we design our cities, for example, or municipalities, that can lead both to increased physical activity, to lower obesity rates, reduced pollution, of course, improve mental well-being, etc., etc. Or healthy and sustainable eating can lead to multiple positive effects: improved health, environmental benefits, food security, resilience, etc. So we cannot address them in silos. That's one important thing when we are looking for measures or policy to take on. I would also like to underline the importance of trust. And that's because I'm representing the Public Health Agency of Sweden today. We are one of the agencies in Europe that has maintained trust and even increased trust in the agency from the public. And I see that my colleagues, they are striving with eroding trust or decreased levels of trust, and how that have negative influence, of course, of participating in immunization programs and listening to recommendations, following recommendations. And it's difficult to say what has been the key factors between this high trust that we see in Sweden. We believe it has to do, of course, to some extent with transparency, that we have been transparent both of what we know and what we don't know about uncertainty in science and certainty in science, and have tried to really also be transparent in a way that we invite the public in the process of bringing out recommendations and guidance. We, of course, tried also to prevent polarization and stigmatization. That's one important thing to feed trust. And try to promote access to information and also to increase health literacy in all groups. We could have done better during the pandemic because we had a slower start with some groups that we called hard to reach. That is not the right terminology, because groups that we have less skills in reaching out to. So it's totally a responsibility for the system to reaching out. But we have tried now to develop skills also to reach out in an equal way to all groups in society. And of course, that also reduces polarization. And also, of course, to combat, as we said, misinformation and disinformation. Very important to do that direct and look at it as an urgent problem, and also a problem that not only has to do with information, but also a distrust problem, where you have to alter the way that you deliver services to all the groups, because there are often something behind disinformation and misinformation, often, I would say. So we are looking upon this trust as an asset for us. How can we use it now when addressing NCD challenges, demographical challenges and behavioral social sciences? Can we use this trust in a better way? And also, how can we nurture it? Because we cannot take it for granted. And we have, of course, to look into more specific details. How come we are in a unique way when it comes to trust in Sweden? It's also something that affects all society. We have a big trust looking into OECD data for all public institutions, but specifically the Public Health Agency of Sweden. And I think we are here talking about crisis challenges. Of course, crisis challenges, I think, can be a good driver and push policy. That's the upside of it. Push to think more co-creation, to think more cross-sectoral work, and to think outside the health system. That's one important part, but also planning society, educational sector, labor sector, etc. Very important to address, and also to lift the burden from the health sector when it comes to promotion and prevention to other sectors. And I think we have been too focused on what the health sector has to do, and have to increase knowledge of how all the other sectors that influence health in society can contribute to a more healthy society. And that's probably my final word, that to be able to a resilient society that has to lean on a good public health. And that's a value that we underline a lot in our total defense system in Sweden. That's one of the assets that we have, a good public health with good immunization programs, self-care, and also, a good health at an individual level. Thank you.
Thank you, Olivia. Big hand for Olivia. So, just a follow-up question. As a Swede, I can't help asking you, do you believe that we in Sweden are in a better position today when it comes to preparedness for maybe a new pandemic or some other health crisis than we were 5 years ago, because we were a little bit caught on the bedside with the sort of COVID-19 pandemic? Do you think we're in a better position now?
Yes, the governmental inquiry, they said that we were a bit slow in the start, so that was the main critical view on how we handled the pandemic, and also that the government should step up and take more responsibility for all sectors, so not distribute it to the Public Health Agency at that extent that the government inquiry sort that we did. Yes, we are in a different and much better place today because of all the learnings and because of the situation, the security situation on a global level. So we have much better stockpiling and supply chain resilience, surveillance systems, much better information and data sharing on a national level, regional level, and global level. And policy also that targets all society, for example. And we have a data-driven system to have much higher extent today, and also with all the networks that we have that weren't that established 2020. So I think now we are much better prepared for a new crisis, but we cannot only prepare for a pandemic or a health crisis or a health threat. We have now to prepare for different threats threatening us simultaneously. So now we are, practicing and studying how we can deal both with climate crisis and health threat and maybe a security threat. So it's not at the same time that to have a better resilience and better preparedness, we have multiple threats facing our society.
Yeah. Rob, do you share, Olivia's view that we are in a better place than we were 5 years ago, even given your quite, challenging introductions to where we are on a number of important topics?
Yeah, I certainly do. And I really appreciate the points that Olivia's brought up. But I think the key for me for possibly Sweden, Norway and Denmark has been this almost militant transparency that you've conducted throughout the pandemic. And that has been a huge, to your advantage in building trust, but also resilience in the communities and their confidence in your ability to lead. Because what those three countries did, and particularly in Sweden, was you communicated when there was nothing to communicate, which was absolutely critical. Yeah. And we learnt it since 9/11. Mayor Giuliani, let's not talk about Mayor Giuliani of New York, but what he grasped then in terms of risk communications, I think was really, really important for us all. They basically had nothing to report for 3 hours after the 9/11 attacks. And he spoke to the public on primetime TV every 15 minutes, reassuring them, making sure that they were clear, they were as uncertain as the public were uncertain. And that's what I think Sweden did particularly well. The other thing I think Sweden does particularly well, and it's something I've taken on personally, is the ability to communicate with populations at their level or in a way that they understand, simplifying very complex issues. And let me give you an example of one thing that I took from Sweden many years ago and have used with ministers of finance and with my mother. And my mother actually was my Minister of Finance for the first 18 years of my life. So they have some similarities. But when I speak to a Minister of Finance today about antimicrobial resistance and why he should be investing, I do not talk about antibiotic resistance. I don't talk about how microbes work. I don't talk about antimicrobial resistance and try and define it for him. I talk about untreatable or hard to treat infections. When I talk to him or her about antimicrobial resistance, I'm laying there in this phone. When I start talking about untreatable infections, excuse me, what was that? Because there's an understanding that an untreatable infection has a huge financial cost to that Minister of Finance. It's exactly the same with my mother. When I had to explain this to her, on 3 or 4 occasions I've tried to explain it. But the moment I explain that this is an infection where there is no treatment, she gets that. She understands that. And Sweden have used that kind of, how do I put that, sort of community lingua around vaccine hesitancy, around AMR, around non-communicable diseases for decades, when other countries have been trying to hold the scientific sort of high ground and communicate the technological and scientific basis for this communication. And it hasn't helped. It hasn't helped at all. Vaccine hesitancy is very clear. Vaccine hesitancy, 3 C's of vaccine hesitancy: complacency, convenience, and confidence. And on the confidence factor, it is absolutely clear that you will build trust around vaccines if you keep it simple and if you make sure that you're not taking a high ground, but that you're engaging communities. You're using insights to understand how they want you to communicate with them. And here again, I think Sweden, I worked, as I was saying at dinner time last night, I worked many years ago in Rinkeby, yeah. and Jarna, with anthroposophic communities and Somali communities 15 years ago in Sweden, well, not so far from here actually, and we had outstanding impact with the public health authorities on shifting the behaviours of the anthroposophic community and the Somali community, who are not vaccinating for very different reasons, but where you have consistent outbreaks of vaccine-preventable diseases. And it all boiled down to the fact that they were marginalized, they were not participating in the system, they were not engaged, they were not asked to deliver health. How do you want your healthcare delivered? Simple questions got us across very strong barriers to vaccination in both of those parts. I could talk more about that, but I won't. Yeah. But my point is, just to completely support what Olivia said, I think Sweden are very much better prepared today than they were for the pandemic.
From your perspective, Annette, we talked a lot about trust, and I think that we are approaching the end to this session in Europe. So do you share the sort of perspective around the vaccine hesitancy? So are you doing anything, I mean, from your perspective to challenge that and to improve knowledge?
So I think I fully agree. I think what you elaborated and confirmed here is true for Sweden, which I've seen, of course, firsthand as well. I think we're facing another challenge now. The global health financing situation has, of course, faced some tremendous shifts now recently and is still doing. So that's something that we have to work on. And of course, it's transparency and education and all of this is extremely important and has been shown success here in Sweden. But it also requires funding, and the funding situation is becoming a little more dire, unfortunately. So that's something that we have to look at, and that's what we at IVI are really trying, as I try to explain, to handle by diversifying our sources, by broadening our portfolio, by trying to stand on many legs instead of just a few, which I think is extremely important. Yeah.
So a final say from all of you. We start with Olivia and then Annette and Robb. If I do 5 final words on. So if we look forward, if from a more positive perspective, what's the most important thing that we focus on during the next 5 years to be in an even better position? So, believe.
May I say something about trust first?
You may say something about trust.
Thank you.
As long as it's
because I would also like to emphasize that trust goes both ways, both from the public to the institutions or agencies, and from the agencies or the government to the public, that you rely that the public are able to use information and make choices, etc. And an interesting fact is that the government a couple of months ago acknowledged the public health agency's mission in addressing the public with communication, and said that we should even address the public more than we do today. So we got a new instruction to the agency that we should address the public more when it comes to physical activity, of course, crisis and pandemics, health threats, but on several areas. And I think that's a good thing, communicating in that way. Okay, what shall we do the next years? I think we can consider public health as an even stronger part of our civil defense system or our resilient society. So public health could be even stronger part in that work. And I think we, as I said in the beginning, impose policy measures that targets several challenges at the same time. Very important to have that policy in place. And I think also more of a cultural thing. We have to change mindset. We are talking about here now infectious diseases and other crises. And I acknowledge that NCDs and other structural changes to our society are also of urgent nature. So sometimes we talk about here and now, and that we can do here and now to have effect in the future. But I think we have to consider this as urgent problems, all of them, that needs to be addressed now. And we have to have outputs here and now, as well as investments in future health. I think we have to use much more of health economy and economics as a leverage for public health policy. We're working in that direction to include health economy to all our policy measures so that we can prioritize and choose wise measures. And I think we have to have two work streams in mind, both enabling and structural interventions on a societal level and interventions that focuses the individual level or groups of individuals. So work on both levels.
So we need more data to convince finance ministers and Robb's mother that we are doing the right thing in the public health.
Yeah, my father, I would say. We are bringing up the fathers and mothers. My father is 86, and he's not working on Saturdays, but all other days.
That's right.
But he's a data-driven guy.
Yes. And at your perspective, what the most prioritized actions going
And just
forward?
to finish that, yes, more data, absolutely, not only for the public, for agencies, but also for companies. We need to define burden of disease. Yeah, what does it mean? What does it cost in order to get companies on board, of course? I think, communication, of course, transparency is key to get the public on board, to have them with us. I think public health is facing, as I said, some difficult times ahead. I think the European scene has to be bold. I think it's important to understand that we can and we will. And I think what the next years will probably require from us is some creativity. I think we have to find ways and find new approaches, find new funding mechanisms, find ways to do this together. And that will, it will require a little bit of creativity and passion.
That's a very good input for the rest of this conference.
Isn't it?
Just let out the creativity. So, Robb, your final words on going forward.
Yeah, great input to the conference, and it also leaves me with very little to say. I think 3 points maybe that would be complementary to what's already been said. Investment in primary healthcare as the entry point for most people's healthcare in the future. investment in workforce competencies, capacities, and encouraging the next generation of healthcare practitioners. And the third point I would say relates more to how we engage new disciplines. Olivia spoke to health in all policies and the need for a multi-sectoral approach, because all of the problems we've discussed are not solvable within the health system. We need other sectors, regardless of any of the topics we've just joined. So for me, that third point would be a multi-sectoral and multidisciplinary, because I'm a social scientist, so I'm going to end with a very biased point, but there are not enough social behavioral scientists, people who are skilled in the humanities and social sciences within the health sector, working on health issues. Whether we look at Ebola, we look at Zika, we look at the pandemic, the challenges we faced were behavioral challenges. They were not medical challenges, ultimately. They were both. I can't be too biased, but they were both. We need those disciplines also at the table. So I'd like to see a change and a shift for us to be less precious about medical public health capacity and open up the sector to other disciplines so that they can contribute more in the future.
Thank you so much for input. A big hand for this fantastic panel.